All right, welcome everyone to another webinar. Today we're actually having a joint webinar between the Clinical Immunology Society and the International Society of Systemic Auto-Inflammatory Diseases. Before I go ahead and introduce our speaker for today, I just want to remind everyone that we have a chat function in our meeting today, the attendee chat. If you have questions for our speaker, please go ahead and put them in the chat and we will address those at the end of the talk. So now to introduce our speaker. Today we have the pleasure of hearing from Professor Paul Brogan about deficiency of adenosine deaminase 2.
Thanks very much, folks. Well, it's good to see. I can see the number of attendees increasing, 85 and rising. So I'm a pediatric rheumatologist who for years has been studying patients with systemic vasculitis and also systemic autoinflammatory diseases. And it turns out that the world of autoinflammation and the world of immune deficiency are increasingly overlapping, as we'll talk about today. Many of you will already have patients with this diagnosis, so forgive me if I'm trying to sell coal to Newcastle. It's a UK term to explain that you may already be experts on some components of this disease. Okay, so this is what I'm going to cover today. We'll talk about the genotype and the pathogenesis of this new recessive genetic disease, the ever-expanding phenotype and how we make the diagnosis, how we treat it, and what the outcomes are so far, and then describe to you where we're up to with the first attempts at gene therapy for this autoinflammatory disorder. And then I'll just mention at the very end the DADA2 Foundation, who are based in America and have been a great driving force for this newly described disease. So the story the story begins for me back in the 1990s when I first looked after patients with a disease called polyarthritis nodosa. And many of the patients that I looked after, children and one or two adults when I was a younger doctor, turned out to have this diagnosis, a newly described genetic disorder that appeared in the New England Journal of Medicine around about March 2014 as 2 papers, and we were really miffed because we were just working up a big family who had a familial polyarthritis nodosa. I'll describe the case in a little minute. With a PhD student, and Sira Nanthapasal, who came to me and said, "Look, have you seen these papers?" And I said, "Well, you better check that gene first." And lo and behold, our family had this gene. So yet again, pip to the post here. There was a group in Israel and a group in NIH. So this is a recessive disease, and I had to change all of these slides because the gene, when it was first described, was called CECR1, but it's recently changed its name to ADA2. So wherever you see the gene, it's referred to in italics, and the protein in normal case. So this is a biallelic loss of function mutations in ADA2, and to summarize, the clinical phenotype presents with recurrent fevers or systemic inflammation without fever, but very unusually early onset strokes, and particularly a phenomenon called lacunar strokes, so very small vessel strokes, particularly affecting the brainstem, systemic vasculitis. This new type of rash that we had to learn. We were very familiar with livedo reticularis, but suddenly this term livedo racemosa appeared, and we had to learn that. And I'll show you some pictures of that in a moment, and variable degrees of hypogammaglobulinemia. Of course, we had heard about ADA1, and you guys are experts on that because of the issues around severe combined immune deficiency. But the ADA2 is predominantly expressed, unlike ADA1, in the serum, and so it's like the extracellular counterpart of ADA1. Deficiency of adenosine deaminase 2 is associated with reduced ADA2 protein concentration, but also enzyme activity measured in the serum. One of the challenges that we've got, particularly thinking about gene therapy, is there is no mouse ortholog. The nearest we can get is the opossum, which is quite an aggressive American animal that it's very difficult to buy reagents for and really isn't a very good candidate for working up an animal model. But a zebrafish knockdown, as described in one of the New England papers, actually recapitulated the phenotype quite nicely with intracranial hemorrhages and neutropenia. So ADA2, the old-fashioned gene was called CECR1, which stood for cat-eye chromosome region 1, which is on chromosome 22 on the long arm, has 10 exons, 28 kilobases, 511 amino acids. There's 4 domains, and to stop all your eyes glazing over, the point I'm making is that mutations have been described throughout the whole length of the protein. So here was a paper from 2016. At the time, there were about 19 different definite mutations identified, and one in particular that had been described very, very prevalent in the Georgian Jewish population, this G47R variant, which in recessive form was associated with chronic leg ulcers, sometimes called Georgian ulcers, but was a cutaneous form of vasculitis of genetic cause. But of course, things move on. I'm going to reveal all of our secrets in the autoinflammation with the next slide. So this is a website that some of you might be aware of. It's called InFevers. So if you just Google InFevers, it's a website that curates all of the known or the commonest autoinflammatory disorders and all of the different variants and linked to the up-to-date publications. And you can see when I went onto this website yesterday, there's now 102 different ADA2 sequence variants that have been linked in some way to disease. So there's, as ever for a newly described genetic disorder, many more genotypes associated with the condition. Okay, so this table is designed to sort of fit in with some knowledge that you probably already have, comparing and contrasting what we know about ADA1 to this other enzyme, ADA2. So at a pure chemical level, adenosine deaminase 2 converts adenosine to inosine and 2' deoxyadenosine to 2' deoxyinosine. But I'm going to summarize this slide and say that activity, it does this chemical thing here, but it also has other non-enzymatic function that we know virtually nothing about, and we can say it's important as a growth factor in the immune system and also for hematological cell development in the bone marrow. So it's expressed predominantly extracellular as a dimer. It's mainly expressed in monocytes, but there are, as you'll probably be aware, more broader immunophenotypes, mainly because it's also expressed to a lesser degree in B lymphocytes. As I mentioned, there's no mouse ortholog, which makes animal model study a bit tricky. It's probably important physiologically at times when there is higher temperature or acid pH, so during sepsis or cancer, where this enzyme becomes much more active in the extracellular space. But its main role is probably as a growth factor, which may be independent of its enzymatic activity, but we really have a whole black hole when we really understand this molecule. This is quite useful because the way that you measure the enzyme activity is by blocking ADA1 activity using this purine analog EHNA. It's a very long chemical name. And so you can exploit that, and therefore any residual enzymatic activity in serum is from ADA2. So how does this disease work? So here's from a recent editorial. It was a paper that I was a co-author on, which basically emphasized that there's not much known about this, that there's enzymatic activity and non-enzymatic, but that the enzymatic activity is probably or possibly important for marrow development. And if you have very, very low levels of enzymatic activity, it really affects the marrow rather severely, and is more likely to be a patient who will present to immunology with marrow failure and immune deficiency. But if you have residual enzymatic activity, you could get a damaged immune system, which is causing mischief, and vasculitis is one of those features. And there's many pathways to vasculitis using this model. Okay, now this was a slide that had some visuals built into it. I'm not sure if it's going to work on this webinar pathology, but essentially, if you're deficient in one of the important things is if you're deficient in this ADA2 enzyme, you get an excess of these pro-inflammatory M1 macrophages and a relative paucity of these rather anti-inflammatory M2 macrophages. Let me see if this schematic works if I click on this button. No, it doesn't. So the idea was I clicked on a button and it showed you these ones getting smaller, these ones getting bigger, and this blood vessel getting hot and angry. So the idea is that one of the important immunophenotypes that drives autoinflammation is an excess of these pro-inflammatory M1 macrophages, producing many pro-inflammatory cytokines. But as you see, one of the key ones is TNF-alpha, and increased apoptosis of these M2 macrophages. So we can summarize and say that monocytes have impaired differentiation towards anti-inflammatory M2 macrophages and polarization towards pro-inflammatory M1. We know that there's upregulation of other neutrophil-related genes, including myeloperoxidase, and also an interferon signature, and the ADA2 is also a growth factor for endothelium. So the pro-inflammatory effect on endothelium is probably indirect, mediated by monocytes and neutrophils, but may also be a direct tropic effect on the endothelium itself. What about the immune deficiency? Well, you are more expert on that than I am, but for those who have studied it, there are reduced memory B cells, not very specific, reduced terminally differentiated B cells and plasma cells, increased mortality of B cells, and the jury's still out whether there's a T cell immune paresis at the same time, but altered T cells in a single patient described in some detail. So it's very clear that to understand the basic physiological role of ADA2, we need much more work. We need to understand better what the actual receptors are in the immune system and where they're expressed. I'm just laughing. Somebody has said, "Love the guitars." Don't worry, I promise not to play any songs at the end of this, although I might have to get out of here. So. To summarize the phenotype as it presents to a guy like me, a rheumatologist and a vasculitis doctor, it's an autoinflammatory vasculitis, sometimes with immune deficiency. And in a bit more detail, these patients may have recurrent fevers, but may have really awful systemic inflammation and absolutely no fever. So the CRP might be 200, but in fact there are no fevers. So fever is not necessary. It's a rather crude of inflammation that's present in some but not all patients. Livedo racemosa, which is a diffuse mottling type rash, rather similar to this entity called Livedo reticularis, and full-blown systemic medium vessel vasculitis that we refer to as polyarteritis nodosa. And many patients who had a relapsing course of polyarteritis nodosa turned out to have this genetic form of the disease. The term lacunar ischemic stroke is a term that's used to describe small vessel stroke. So in fact, you can have strokes, particularly affecting the brainstem, and these strokes may not even appear on an MRI scan. So you may develop suddenly a third nerve palsy, and the MRI might be normal, but you've had a definite stroke. And it turns out that the brainstem is quite unusual in its anatomy, where you get relatively largish muscular arteries coming off and feeding directly into much smaller vessels, and that causes more shear stress. And so these vessels seem particularly prone to these lacunar type of ischemic strokes in DAVA2. But you can also get hemorrhagic stroke, and I'll show you an example of that in a moment. Immunodeficiency I've mentioned. But the other thing you need to be aware of, it can present completely to the hematologist with complete bone marrow failure or even pure red cell aplasia, mimicking Diamond-Blackfan syndrome. And the other curious thing about this that we now know is that some patients maybe have no symptoms whatsoever. We know this from studying consanguineous families, where we've worked out that one of the parents has got the full-blown genotype, absent enzyme activity, and absolutely zero signs. So we rather pessimistically describe that person as pre-symptomatic. In other words, some trouble coming in the future. But the vast majority of patients present early in life with clinical features. So this is where we are up to. We were just talking before you came on about how hard it is being a clinician scientist. We have a new young clinician scientist who's joined us, and we've just put together the 29 patients that we've picked up over the years. So median age of 15 years, ranging from 2 to 39 years. Some of these are older family members that we've picked up who are pre-symptomatic, usually with symptoms beginning at the age of 5. 25 out of 29 are on anti-TNF, but there's 4 patients who are not, and we'll talk more about that in a minute. 1 underwent allogeneic bone marrow transplantation or hematopoietic stem cell transplantation, and 2 are currently being worked up for that. And 1 died whilst being worked up for allo with a late diagnosis, basically a necrotic gut and marrow failure. And the important one about this case was diagnosed while he was on the intensive care unit, and his sibling had been worked up as the donor for potential allo HSCT. But that's the wrong thing to do until you know the genotype of that sibling, because there have been well described instances where the sibling has donated the stem cells, but in fact has the full-blown genotype, and you just give back the patient the same disease because the donor was pre-symptomatic. So that's an important caveat that we'll revisit in just a moment. So what are the clinical features? I thought rather than just list those, I'll show you some stories. So this was a boy who presented to me at the age of 13. And what this slide shows is that he's got a black finger. In fact, both his fingers are black here. And he has these sort of nodules on the sole of his foot. And this is a biopsy of his sural nerve, and that's an artery within the sural nerve on the back of the calf. It's an old-fashioned way of diagnosing medium vessel vasculitis. You can access the nerve quite easily, and this is an artery, and what you're seeing here is fibrinoid necrosis. So that's classically what you see in necrotizing medium vessel vasculitis, such as polyarteritis nodosa. And he was interesting because at the age of 3, he'd actually first presented with a so-called idiopathic arterial stroke. He was very inflammatory at the age of 3, but then was completely lost to follow-up and was put down to just one of these kind of presumed post-varicella type strokes. But in fact, what he had, and he was the first index case of a big family with deficiency of adenosine deaminase 2. He had no immune deficiency. Here is a second case that was sent to us, and this is a boy who clearly looks dysmorphic. He's got some problems with his hair. He got sent to me with no diagnosis. This was in about 2013, before this genetic disease had been described. He developed an ulcer that had gone into the bone of his right leg, and he'd required an amputation of that leg. And the worrying thing was, you'll see he's got an elastoplast here, and that revealed a similar process. When you remove this gauze here, this also went down to his bone. This is the livedo racemosa shown here. And in fact, what we're able to show following the discovery of the gene for this disease is that he had compound heterozygous variants in the CECR1 or the ADA2 gene, but one was strictly speaking a variant that hadn't been described in the 5' UTR, low ADA2 enzyme activity, which allowed us to secure the diagnosis, and as I'll show you a little bit later on, save his remaining leg. The sting in the tail, however, his completely asymptomatic younger sister has got exactly the same genotype. She was only age 5 at the time, and she also had low ADA2 enzyme activity. So we converted the burden of unknowing in this fellow to the burden of knowing in this pre-symptomatic individual. So this is a disease that comes with some really quite nasty twists and turns for family and genetic understanding. And this was one of the first cases that I looked after, and this was a case that we had written up in 2003. It was a girl who had classic polyarteritis nodosa. This is a digital subtraction arteriogram of the kidney. You can see a large aneurysm here. You can see the lower pole of this kidney is absent compared to the upper pole because it's ischemic. And in fact, this is the image that appeared in many of the pediatric nephrology textbooks as classic polyarteritis nodosa. This is showing what's described by the ophthalmologist as a skew defect of the eye. So it's a brainstem infarct shown here. And a bit later on in her story, she bled into her brain, but an angiogram of the brain did not reveal any large aneurysm. In other words, it was a hemorrhagic small vessel stroke. And many years later, when she was in her mid-20s, she was only about 5 here, we called her back, or at least called her DNA back with her permission, and made the diagnosis of deficiency of adenosine deaminase 2. So many patients with this relapsing course will have this disease, and the diagnosis may only be made in adulthood. And then lastly, this was one that was sent to me from the immunologists in Birmingham in the UK. So this was a family where a number of the girls had so-called autoimmune neutropenia. They were neutropenic. They had anti-neutrophil antibodies, and by the way, had these terrible ulcers. But in fact, the anti-neutrophil antibodies were a complete red herring, and this was deficiency of adenosine deaminase 2 and severe recalcitrant marrow failure. And this is a patient who, as you can see, has had areas of extensive necrosis, has ongoing vasculitic lesions, and you can only go so far to cure these with my sorts of treatments that we'll talk about in a minute, because they don't affect the bone marrow when it's failing. Okay, so let's just run through the different specialists that might see this disease. So we've already mentioned the marrow failure phenotype, which can be a pure red cell aplasia, and is one of the genetic causes of what looks like Diamond-Blackfan anemia. And it's important to note that these marrow features may occur without all the vasculitic features that I've shown you. There's an unusual Castleman phenotype, so this giant lymph node hypertrophy. This was described by the group from Belgium, a male age 5 who had presented with a classic Georgian mutation, who had these giant lymph nodes, very high interleukin 6, avid FDG uptake on a PET scan, and did very well with anti-IL-6 treatment, although that was the exception, I would say, rather than the rule. Tocilizumab is really not a good treatment for this disease, as I'll describe in a moment. But you should be aware that it falls into the Castleman's sort of immunoproliferative spectrum as well. And then, of course, the immune deficiency phenotype. And this is one of the most extensive papers. It's a few years old now, in 2017, essentially presenting to you as a common variable immune deficiency. And of 181 patients with antibody deficiency, 11 cases had DADA2 as the cause. That's a reasonable number, with a broad phenotype ranging from isolated antibody deficiency to those with immunodeficiency plus vasculitic manifestations, including strokes. And B-cell function also correlated with inflammation, implying that if you in some way control the inflammation, you may be able to reverse some aspects of the immune deficiency. And then, of course, autoantibodies and an autoimmune phenotype, unsurprisingly, with this interferon signature that you can see, is also might be observed with high ANA titers described in a handful of patients. So a pretty broad spectrum of presentation and a great mimic. So you have to be ever alert to this as a possibility. So what are you going to do about that? How are you going to diagnose this? Well, really, there's no magic about this. You just think, you sequence early on, and you think again. Is the mantra that we teach in our institution, and I suspect for you guys as well. So this is the unholy trinity between autoinflammation, autoimmunity, and immune deficiency. And when I'm in clinic, of course, you don't know what the hell's going on with your patient. You just have to say, I don't know if this immune system is overactive, underactive, or a bit of both. In other words, is there immune deficiency, immune dysregulation, and autoinflammation? And in fact, when you think about it in that way, DADA2 in this Venn diagram spans around about here, overlapping between autoimmunity, autoinflammation, and your diseases with immune deficiency. So I find myself getting involved in cases that in the past I may have had no right being involved with, but that's true of many autoinflammatory diseases that are emerging. So when do I consider screening for DADA2? Well, this is a little bit of a lie. I wouldn't want you to think that we just do single gene tests. Of course, what we do is we at our institution either do clinical exomes or a very broad panel targeting all of the diseases that we're interested in. And the one that we use is called the VIP panel, which stands for the Vasculitis and Inflammation panel. And Ada2 is one of the genes on there. So we use a next generation sequencing approach. So it's part of the workup of any patient with systemic autoinflammation. But if you want to focus in, the specific indications is early onset polyarthritis nodosa, and we can arbitrarily define that under the age of 10, but it might be in adulthood. Certainly if there's a familial vasculitis, polyarthritis nodosa type picture. Within PAN, you can begin to sniff out those who've got DADA2 by the nature of the rash and the type of strokes, and there are many other situations. But it would be disingenuous of me to say that we have a specific remit for DADA2, and we have picked up cases that we would have thought would not have been DADA2, mainly by having a broad next generation sequencing approach. But it's also important to complement your genetic testing, which I mentioned here. Here's a paper describing our vasculitis and inflammation panel. This has been incredibly useful to us and has transformed the way that we think about diseases. No longer do we do this old-fashioned trying to best guess the genetic diagnosis. I just think that that's just fraught with difficulty and is inefficient. So use next generation sequencing early. I don't think I need to emphasize that to you as a group of immunologists. But what's very important is that you should have access to either the protein assay or the enzymatic activity. We prefer the Diazyme kit, and as I mentioned to you, we exploit the EHNA as the ADA1 inhibitor, and therefore measure residual ADA2 in the serum using that, and that's been very important for us. There are other methods, and in North America, the Hirschfeld lab at Duke used a coupled spectrophotomic assay, which is very sensitive, but perhaps does not give you enzymatic activity. And it's important to consider enzymatic activity because it turns out that children have higher physiological enzymatic levels than adults. So it's a normal phenomenon that levels are high in childhood and then decline with age. That's very important when you're considering your reference ranges to compare your enzymatic activity diagnostically. So here's some data that looks at children. If you focus on the green dots, that's healthy pediatric controls. And as you can see, they have higher ADA2 enzyme activity in the serum than adult controls. And these are DADA2 patients, as you can see, is very low. It doesn't matter if you're less than 18 or over 18. It's pretty binary. And adult carriers might be a bit lower than healthy adults, sort of in between type activity from haploinsufficiency. And it turns out this is important because, as I mentioned to you, if you have residual ADA2 activity, it might explain why you have more immune dysregulation, autoinflammation, vasculitis, as opposed to virtually no enzyme activity where you get more of the spectrum that's going to present to you guys with marrow failure or to the hematologist with pure red cell aplasia. So it seems that there's a genotype-phenotype correlation, at least when we consider residual enzymatic activity. And that's true of other autoinflammatory diseases, for example, mevalonic kinase deficiency, where very low levels are associated with a severe metabolic disease with neurological problems, but some residual enzymatic activity in that disease associated with a more autoinflammatory phenotype. Okay, what do we do about all of this? How do we treat this disease? Well, it turns out that there's been no formal trials, and interestingly, these days when you write a grant, you've got to always involve your patients, and when you do involve your patients with DADA2, they give you a surprising message. They do not want a clinical trial for DADA2. They just want access to anti-TNF and would regard it as unethical to do a trial with anything other where everybody gets anti-TNF, and that was a pain in the butt because we were designing a trial at the time that was going to explore different biologics and would include deficiency of adenosine 2 in amongst other ANCA-negative vasculitides. So we scrapped that part of the trial and we're left with retrospective data. So we can say that anti-TNF is very effective for the autoinflammation and vasculitis, but not for marrow failure, not for the immune deficiency. And it seems that over time, the patients that I tried here, there's some loss of efficacy, probably due to anti-drug antibodies. So if you use your anti-TNF too early in life, you may run out of options early on. Allogeneic hematopoietic stem cell transplantation may be curative, but there's important caveats. So what about the anti-TNF story? So here's our boy who had lost one leg. This was in 2015. Humira is the trade name for a form of adalimumab, a humanized monoclonal antibody against TNF-alpha. So soon after we made the diagnosis, after the disease was discovered, we started it on this boy with broad-spectrum antibiotics because he had some exposure of bone here. And you'll see from early 2015 to September to November, healing of this ulcer, which gave us great N of 1 confidence that anti-TNF was profoundly efficacious, at least in this boy, for ulcer healing. I should say that his systemic inflammatory markers were completely normal right the way through all of this. I'm just seeing a message flagging up from Chip Chambers, who's the founder of the Patient DADA2 Foundation. Hi Chip, I look forward to answering your question at the end of all of this. So we've just put some data. So Samantha Curry is our young fellow, and I said, Sam, tell me how good anti-TNF is, because in my country it's very hard to get hold of it. We're going to have to persuade Boris Johnson and the NHS it's good value for money. So Sam went off and she worked out that these were patient months before anti-TNF treatment and after. She divided vasculitic events into those affecting the CNS and those affecting the non-CNS, so black fingers, black toes, that sort of thing. As you can see, very high before anti-TNF, very low, but not zero. And it turns out the ones that weren't zero, there was a bit of mucking about going with the dose of anti-TNFs, and probably too low a dose. But it is true to say at least two stroke episodes have happened on anti-TNF, but probably because of too low a dose. But pretty impressive results. And if you compare total ischemic events to before and after, and correct that for patient months, you see a highly statistically significant difference, which is why the patients are telling us they don't want a trial. And it occurs to me that this is historically about the second time in autoinflammation this has happened. The first description of colchicine for the treatment of familial Mediterranean fever was published in the 70s in the New England Journal of Medicine and involved about 10 cases, and it worked so well there was no need for a clinical trial. problem is that it's quite hard persuading people to believe that, who have to fund the drug, but there you go, we agree with the patients on that one. And similarly, this is a paper that was published by Amanda Umbrello from NIH last year. There's two parts. The first part to focus on is the C part of the graph here, which essentially shows exactly what I've shown you from our series. So this is patient corrected months, 733 both sides, 37 strokes pre-anti-TNF, 0 strokes in the NIH series after. And I'll maybe ask Chip to tell us if he's hearing from his foundation about patients who have had strokes that have not been yet described after anti-TNF. They also attempted to try and replace ADA2 by infusing plasma, but in 3 patients, but it really was impractical. The half-life was 4 or 5 hours. So plasma infusion and replacement of ADA2 via that means is really not a helpful thing to do. But Chip might tell us about attempts to have a pegylated form of ADA2 to replace this, much like what you've done for ADA1 replacement. But the treatment key message is that anti-TNF is good news, significantly reduces vasculitic disease activity, prevents strokes, but is not effective for immune deficiency or marrow failure. There's a question that's flagging up. I'm going to answer it straight away. It's for life. So once you start these patients on it, it is for life. Yeah? All right, so what happens if you have got one of these poor patients with marrow failure, or you've had anti-TNF and you've developed anti-drug antibodies some years down the line? Well, the good news is that you can have allogeneic hematopoietic stem cell transplantation with caveats. So this was a paper from a few years ago now from Isabel Mates, one of your colleagues from Belgium. This described, there's probably been about at least 30 or 32 cases transplanted now, but 14 at the time from 6 different countries. The indication for HSCT was bone marrow dysfunction or immune deficiency. 6 out of 14 also had vasculitis, and at the time this was published, all the patients were alive and well, 18 months of follow-up, with no new vascular events and resolution of the marrow failure. And the key point that Isabel made in her paper was that HSCT represents an effective and definitive treatment for DADA2, may cure the immunological, hematological, and vascular phenotype with 100% survival at median follow-up of 18 months. So it's an option for you. So don't muck about if you think you've got the marrow failure phenotype later. But like all of these things, there are a few caveats. So in that series of 14 patients post-transplantation, hematological autoimmunity and cytopenias were described in 4 out of 14, so just about a third. Acute graft versus host disease, as you would expect, in about 6 out of 14. Adenoviral infection reactivation was common in 2/3. And disease relapse also occurred with a drop in donor chimerism to about 30%. And also there were 2 cases where the donor was the pre-symptomatic sibling. In other words, they didn't check the genotype in the asymptomatic sibling, but in fact the disease came back because they had recessive disease and just were pre-symptomatic. So if you're using a donor, they really should be screened for this disease, particularly if it's a familial donor. Right, okay, so what about gene therapy? It turns out that this disease was one of the most recent in the autoinflammation world to be described, and probably is going to be the first that's going to be amenable to treatment with gene therapy. So in November 2018, we made a promise to the patients at the DADA2 Foundation that Chip runs that we would have human trials within 7 years. We've been slightly slowed up by COVID, Chip, but I think we're still on target before you ask that question. So where are we up to? So we've been for about 5 years now basing the hypothesis that the gene transfer strategies, it might be possible to correct the in vitro defects associated with DADA2, as you have done as a community with ADA1 SCID. So the objectives of this program of work that's led by Despina Alefthru working in our group, first of all, we developed an ADA2 knockout using CRISPR-Cas9. That was really helpful because remember, there is no mouse to play with. So this was a human cell line that we could begin to play around with and do gene knockout experiments. So we got that working. We then developed a self-inactivating lentivirus with the EFS promoter. EFS is one of the standard ones that's used in human clinical trials. It's a promoter that's ubiquitously expressed because, as I mentioned to you before, this is a protein which is expressed throughout the immune system, predominantly in monocytes, but also in other cells. So we really want to target all CD34 lymphocytes. And we can now take a patient's cells who's got DADA2 and completely correct the enzymatic serum activity we can overexpress it, and we can get it back to normal as well, and it completely normalizes the immune phenotype of the cells in a test tube. So these are all preclinical studies. So here's a bit of data about that. So this is one of the first experiments of transduction at ADA2 patient-derived macrophages, restoring the ADA2 function back to normal. And here is a slide that shows us that we can switch off anti-TNF production before and after transduction in this patient cells in a test tube, thus rescuing the immune phenotype. I also mentioned to you that the other part is this reduced M2 problem that you have, and what you can do when you restore the ADA2 activity is reduce the amount of M2 apoptosis back down to healthy control levels. So it's all looking very positive at the moment in a test tube. Chip Chambers and I and others had a call about 18 months ago, maybe 2 years ago, about the opossum, and decided that it's going to be faster to work to humans rather than it would be to develop a program within the opossum, for all the reasons that I mentioned. Very aggressive animals, hard to animal husbandry, is difficulty with reagents. But the next step for us, in the summary for this part, is that we can recapitulate the THP1 cell line, the immune phenotype, by knocking out using CRISPR-Cas9, and we've got these cells in liquid nitrogen. They're useful for experiments, but just our test tube experiment. We've got a self-inactivating lentivirus using a promoter that's used for gene therapy clinical trials. It seems to be working so far. The next step for us, we've got it working in CD34 hematopoietic stem cells, but now we're getting access to CD34 cells from DADA2 patients to make sure that we can do that. And then we'll be moving into a rather crude NSG mouse model to examine for genotoxicity, etc., and go through the regulatory requirements that you will probably understand as a community better than me as a rheumatologist. So we're just at the moment with teaming up with the NIH to harvest some cells from DADA2 patients and graft those cells once we've transduced them into an NSG mouse and test the genotoxicity. So work is moving forwards, and I really hope that we can get the first patients through to trials before, within the next few years for sure. I stopped talking and I really want to make sure we've got enough time for questions. So I'll conclude by saying recessive mutations in ADA2 cause a monogenic form of vasculitis with variable degrees of immune deficiency and cytopenia. To remind us all that the clinical severity can be heterogeneous, from asymptomatic or pre-symptomatic individuals through to those with severe rip-roaring strokes and vasculitis. The anti-TNF is particularly effective for autoinflammation and stroke prevention, but there's no formal trials, nor is there likely to be. We just need access to the medicine. That you've got the option of allogeneic hematopoietic stem cell transplantation, and gene therapy might be an option for the future, and certainly we're working hard on that as we speak. So I just want to give a big up to Chip. I'm glad to see he's on the call. The DADA2 Foundation have been really fantastic, and I hope Chip gets a chance to say something at some point to you all. But anyway, he's on the call asking questions. Here's his website. Go and visit his website. It's really cool. And there's their catchphrase: we need each other. We certainly do. And I think the rheumatology and the autoinflammation community definitely have benefited from teaming up with you immunologists to learn about gene therapy, because you're the leaders on that. These are some of our funders for the gene therapy and other work. The Arthritis Research UK ambitious call for cure. We think DADA2 might be one of the diseases. I always hesitate to call it a cure, but you never know. We might get there with gene therapy. And as you can imagine, this is not an effort from just me. There's many people involved. Just want to mention some players that you'll know. Adrian Thrasher, involved in your community when gene therapy work for primary immune deficiency. Stephen Jolles is an immunologist, various other folks. So I'm going to stop there, and I'm really happy to take questions from you all.
All right, thank you so much, Professor Brogan, for this fantastic talk. Again, folks, this is Carolyn Balo. I am your moderator for today's talk. So if you have any questions, please go ahead and put those in the chat. We'll address them now. And we've had several accumulating through the talk. So first, we have a comment from, and I apologize to anyone if I mispronounce your name, Amit Rawat, who had commented that Hodgkin lymphoma has also been reported. We are following a family with 3 siblings.
Yeah, that's absolutely right. And, you know, it really doesn't surprise me. We've known for a long time that people with chronic inflammatory diseases so for example, lupus, patients with lupus seem to have more propensity to hematological and lymphoreticular malignancy. And so we're aware of this. We're aware of this. So I had 2 recent siblings who presented to me, and they came via the cancer doctors. They presented with a rash, nodular vasculitic rash. And when they biopsied that rash, they were very worried that this represented a T-cell lymphoma of the skin. I thought this was incredibly unusual because it was affecting 2 siblings. So when we got the genotype and the low enzyme activity back, I pointed out that many cells can look when they're very activated like malignant cells. But in that context, these types of discussions, so yeah, I think that lymphoproliferation in its broadest sense, that may be benign or tip over into malignancy, is certainly a concern, as Amit has mentioned. So hopefully that acknowledges that I agree with that point.
The next question was from Mark Resnick, who asked, what was the significance of the little girl with multiple views of her eyes?
Yeah, that was just to show that this is a girl who'd had a brainstem infarct and had a problem with her conjugate eye movements. It's called a skew defect. So the point is that here's a rule of thumb for you, a clinical nugget: polyarteritis nodosa with a squint, think DADA 2, because as I mentioned to you, the brainstem is particularly susceptible to lacunar stroke, and all of the ophthalmologic nuclei are in the brainstem. So when the neurological involvement involves brainstem nuclei, think DADA 2.
And next we had a comment from Nicola Wright, who said, FYI, it looks like the gene is not included in some of the commercially available bone marrow failure and Diamond-Blackfan anemia genetic panels.
Yeah, you should get in there and ace them and make a fortune. That's what you should do. I agree. Just remember, though, that the gene has changed its name, so just check both CECR1 and ADA2. But you're absolutely right. We're seeing this all the time. So another it's a talk for another day, but another disease that I look after is called SAVI, and that can present with lung fibrosis. So we had a girl who's just recently undergone a lung transplant, and after the transplant has the diagnosis of this complicated vasculitis of infancy, and exactly the same conversation was from the lung transplant team. Oh my God, this gene is not on our list of interstitial lung disease genes. They're all looking at surfactant deficiency and all of that. So the specialisms are overlapping, and it argues strongly for being very inclusive with clinical exomes, which of course you can broaden because all the genes are included or should be included. But absolutely, there's no such thing as a negative genetic test. You need to know what genes were tested before you can say that with any confidence.
And then sort of going off of that, Scott Kina asked, are there enough cases to intuit any genotype-phenotype correlations?
I was, Scott, hi Scott, I thought Intuits were a form of Native American, or is that Inuits? I can't, Intuit's an odd word for me in English. So Pui Lee from Boston, Scott, in fact, has got that nice paper. He sort of roped us in, and he began to look at the genotype associated with forms that have got some residual enzyme activity. So that was that slide that I showed. So that Dan Kastner has written a nice review. So I nicked Dan's slide. So I think that we're beginning to see some genotype-phenotype correlations, but it still, to me, doesn't explain how some it's a recessive disorder which is variably penetrant. So it absolutely we can begin to look at genotype-phenotype correlation, but I still don't understand why some patients in their 40s and 50s are pre-symptomatic. I just don't understand that yet. So I think we've got so much to learn, but we can make some tentative steps, I think, Scott.
And then Chip Chambers commented, some work is being done on PEG-ADA2.
Yeah, so Chip, I presume the members of the audience can't speak. Normally what I'd say for a difficult question like this, that's a great point. Do you want to tell us all about that? So maybe Chip will type. But so the idea is, of course, everyone is looking for a more targeted treatment. If it's an enzyme that's missing, can you give a pegylated form that will stay in the blood a bit better than plasma does, and just replace it? And of course, that's very, very attractive to drug companies, isn't it? Because it's a lifetime of expensive enzyme replacement therapy, a bit like in Fabry disease, for instance. I suspect that this may have limited use, but it could have some use. So, for example, it might be it's a sort of treatment. So, say you're waiting for for gene therapy, or you're waiting for a bone marrow transplant, and anti-TNF is worn off. It might be the sort of thing that you could give as a bridge to a more definitive gene correction type of treatment. I don't know. I think the more therapeutic options we have, the better, because it's clear some patients are escaping efficacy from the standard treatments, which at the minute is anti-TNF.
And then the next question we had already addressed, and so now one from Ivana Aksentievich. What should we recommend for patients in poor countries who do not have access to anti-TNF therapies or the possibility to have HSCT?
Before I go to Ivona's question, I'm going to go back to Rakesh.
Okay.
So the answer is for life. But here's a really thing, and myself and the NIH team often have this debate: is when should you start anti-TNF? So when we started this off, I found it very difficult to start my patients on anti-TNF who had no symptoms, and they went along with that. And more recently, I started getting a bit worried. Amanda, Umbrello, and Ivona and others said, "Look, you should start it whenever." And so for some patients I've done that, but some of the patients have said that they don't want to start it. They'd rather wait for when they really need it, because they're very conscious that anti-drug antibodies may form, and they don't want to take it at a time when the child is quite well. And that's a dicey game to play, because the first episode they might have might be a life-threatening stroke, or at least a life-limiting stroke. So it's a really tricky time is when to start treatment. But the easier answer is once you've started it, it's for life, Rakesh, as I mentioned. So then, Ivona, I regard my country as a poor country because, as I've said to Chip in the past, in the UK, apart from at my hospital, the amount of paperwork that you would have to fill in to get access to this for DADA2 is just prohibitive. So we're working with our government to try and correct that. So I regard the UK as a poor country who can't afford anti-TNF for this devastating disease. And yet, if you've got a bit of uveitis and GIA, you can get access to anti-TNF, no problem. So what should we recommend for patients in poor countries? I don't know. I wonder... What do you think, Ivona, is what I'm going to say? I have no idea, because as far as I'm concerned, you can rescue people with corticosteroids, but steroids are associated with toxicity, but that's cheap, so prednisolone. Judicious use of aspirin. So there's this world, if you've had a stroke and it's non-hemorrhagic, you may consider an anti-aggregant agent such as aspirin or dipyridamole, probably aspirin these days. But that's a bit tricky in DADA2, and we have used judiciously aspirin, but you for short periods of time when you've had an acute ischemic episode, for example, of the testicle without hemorrhage, you can add a bit of aspirin. So there's antiplatelet agents and other anti-inflammatory agents. I have no idea how effective thalidomide is in this situation, but as you know, thalidomide was used for many years as a cheap medicine for the treatment of Behçet's disease, may have some anti-TNF activity. There must be some patients out there who have inadvertently received cheaper medicines like thalidomide, but I'm really scratching at the bottom of the barrel, Ivona. I don't know. I think it's terrible. I think we should have a mechanism where they can get cheaper versions of anti-TNF, is what I would say. Right.
Wonderful. And I'm just going to make a note that we do have Chip Chambers with the ability to speak. So Chip, we'll come to you at the end for you to make your announcement.
Oh, that's great.
Our next question, Ankur Jindal. 3 of our patients with polyarteritis nodosa responded to steroids before they were diagnosed to have DADA2. Would you recommend anti-TNF for these patients to prevent relapses? And as a follow-up, any preference between adalimumab and etanercept?
Yeah, so the answer is yes. So once you've made the diagnosis of DADA2 and you've had some trouble, for me, I usually, when I start off treatment for the vasculitic manifestations, I give some prednisolone or methylprednisolone, depending on the severity, and then tailor that off over 6 to 8 weeks, depending on how severe the child is. So I usually add the two in together. So a targeted treatment plus a deliberately non-targeted treatment. So once you're in trouble from DADA2, you're on treatment for life. Yeah? So the answer is yes to that. There seems to be no difference between adalimumab and etanercept. In other words, anti-TNF is good. The one that I don't use anymore is infliximab, because obviously that's got more mouse protein in it and much more ability to make antibodies. So I avoid infliximab, but adalimumab and other biosimilars, absolutely fine. Etanercept, absolutely fine.
Right, and the next question from Hal Hoffman, is there any heterozygous phenotype?
Okay, so I've got a patient who's a doctor who's pretty convinced that her daughter has got a heterozygous form. I just don't think there is. All of the so initially, when for example, at the first talk I gave at CHIP's conference in 2016, I was describing a case where I was worried that there was a heterozygous patient, Hal, but some months later we found the second mutation. Ivona's got a recent paper that emphasises the 5' UTR that we had found, and so I think there may be some hidden mutations, for example, in intergenic regions or in other regulatory regions that may not be exonic. So the answer is it's possible, but it may be that because there is a second mutation, but you just haven't identified it using whichever next generation sequence methodology. But Ivana is definitely the expert on that these days. Anyway, good to see you, Hal. I wonder what the waves are doing in San Diego. Next one is from Tamara.
Yep. Also curious about heterozygous phenotype. A carrier mother of 2 of our patients had unusual cold urticaria since childhood and some mild immunodeficiency symptoms.
Yeah, the way to solve this puzzle is to measure the enzyme activity. So this is definitely a disease where you want to have genotype and a functional assay, because if you've got one pathogenic mutation, you're suspicious. If you then demonstrate low or absent enzyme activity, there's going to be another mutation there. You just haven't found it yet, but you've solved the puzzle at that point. But to be honest with you, if you were particularly worried and you don't have access to the enzyme, do contact us, because we've now set it up as a routine assay. And the other thing is that at Duke, definitely they've been offering that, and they cover large parts of North America. So I think the key is to get the protein and the enzyme activity measured in that situation. I've lost you all. Can you all hear me?
We can. Can you hear us?
You're now back online. I think you dipped out there for a wee minute.
Okay, so this next question was, what is your approach for treating the bone marrow failure patients if HSCT is not possible for various reasons, like lack of donor or parent refusal?
I would put them onto a bit of steroid, give them anti-TNF and varying doses of GCSF. Is the best thing you can do. But a tricky one, that one. Hence why things like pegylated ADA2 or gene therapy is really going to be important moving forwards.
Right, and then we had a comment from Chip Chambers referring to some earlier discussion, saying there was a small biotech working on the compound. Agree if anti-TNF is not working. And then our next comment or question came from Roni Greenberg, who said, regarding symptoms, could you comment about the skin rash, please? Does it come and go? Also, can the ESR be normal?
Yeah, that's two great questions, Roni. Okay, so the answer is ESR and blood tests can be completely normal, even when you're infarcting a part of your body. So one of my patients came in. I do a clinic on a Friday. His father's a doctor as well, actually. Came into my clinic on a Friday. He said, oh, he's doing absolutely fine, thanks so much, no problems at all. He's had this pain in his testicle for the past 24 hours. And his testicle was swollen and he'd infarcted his testicle. And the ESR and the CRP were absolutely plumb normal all the way through. So the answer is yes, you can have systemic vasculitis and completely normal acute phase reactants because the inflammation is all happening at the endothelial level. Skin rash, okay, so let's learn two words. So we learned this diffuse motile rash, but the guy in the hand that I showed you is called livedo reticularis. And there were two forms when I was coming up that I learned about. There's so-called constitutional livedo reticularis, which is sort of diffuse and maybe normal. For example, people with pale complexions, adolescent females can have that sort of diffuse mottling. But broken livedo reticularis, which is when it's just affecting one part of the body. The other name for broken livedo reticularis is livedo racemosa. So that's how you describe the rash. What seems very clear from different studies is that when you give people anti-TNF, that the rash is always there. So it's the one feature that never goes away completely. But it can come and go in its severity, but it never goes away completely. in answer to your question, and that's also true post bone marrow transplantation in our experience as well. So hopefully that answers your question, Roni. Two good questions there.
Right, and then next we have Sybil. I apologize, I'm not going to try to pronounce your last name, but the question was regarding the heterozygous phenotype. Since the protein dimerizes, wouldn't it be possible to have dominant negative mutations?
Could be, it could be, and you know, we are a community that's looked after a disease that for many years we called autosomal recessive, to realise that we should have been calling familial Mediterranean fever autosomal dominant with variable penetrance and a gene dosing effect, and it may be that will prove to be the same for DADA2. So I'm very open to that and certainly agnostic on this important question.
All right, and then Luis, another last name, I apologize, but I'm not going to try because I will butcher it. One of my patients with ADA1 had clear libido racemosa before transplant. Have you or any of the immunologists in the group seen that in ADA1 patients? I found it interesting, but could not quite fully explain it.
I think that's definitely a question that I need to pass over to you guys, because I don't look after SCID patients. From a general perspective, you know, if you have immune deficiency, you may have, you know, as I said, an underactive immune system plus some immune dysregulation, so a bit of autoinflammation, and you can get various forms of vasculitis that can be, you know, secondary to immune deficiency. So it really doesn't put me off seeing a bit of a libido racemosa, but I'd be interested to hear the views of others on the call.
If anyone does have any input, please go ahead and put it in the chat. And in the meantime, I would invite Chip Chambers to go ahead. Oh, I'm sorry. One more question popped up here. Scott Kana again. Apologies if I missed it. Interferon score nonspecific or represents pathology?
Yeah, it's a great question, Scott. So as you know, some work from Yannick Crow had shown that you can find an interferon signature within the blood of patients with DADA2. I think beware trying to make any diagnosis just on an interferon signature. So for example, the signal that's not screaming through is the use of JAK inhibition for DADA2. Yeah, so if it was very important to the treatment, it would be a very good therapeutic target, and I'm really not seeing that. This is a disease that seems to respond better than any I've seen to anti-TNF. I think it's there, but it may not be as important, at least as a therapeutic target, as for some other diseases. So hence why it's very important. We have the interferon score. We set that up in a routine lab as well. And we like to have that information in conjunction with the genotype. So it's the synergy between a functional readout and the genotype is much more important to a clinician and to your patients diagnostically, I think.
All right, and now, Chip Chambers, if you are able to speak, I know you had an announcement you wanted to make, and I'd certainly offer any additional comments you'd like to add based on the discussion we've been having.
Hey Chip, I wonder if you're on mute.
In the presenter view, up at the very top center is where you can see if you're on mute or able to unmute yourself. We still can't hear you. I don't think there's any other functionality in the program here.
I'll say what I think Chip is going to say. So Chip has organised the third DADA2 Foundation meeting. And Chip, I think it's going to be, you told me this week, and it's gone straight out my short-term memory, but I think it's in December of this year, and it's going to be a virtual meeting this year. And so I think what Chip will be doing is inviting the immunology community to look at his website and to see about participating in this, because the Data 2 Foundation have been absolutely brilliant. For those of you who want to help your patients or finding it difficult to access medicines, they've been great advocates for that. They also help you with your grant applications. You've got fast access to the world community of patients, and Chip has done a truly tremendous job. I can't say enough good things about it. Chip, I'm probably not bigging this meeting up enough. You would do a much better job if we could hear you. But go onto the Data 2 Foundation website that Chip has set up. It's truly exceptional.
And he has also actually sent us that the dates are November 17th, 18th, and 19th for the virtual conference. And he said, if you are not part of the Data 2 Foundation Physicians database but would like to attend, to email him at chip.chambers@data2.org.
Fantastic.
So, Professor Brogan, any final comments, thoughts that you would like to share in closing?
Well, we were talking just at the beginning. I think it's lovely to see the two communities of autoinflammation and immunology come together. Certainly, I'm working much more closely with immunology than, for example, nephrology that I used to work with. And I just think that we as a community in autoinflammation have so much to learn from you guys, particularly as we move into the era of gene therapy, because you guys have definitely paved the way for that. So we're following on your coattails. So thanks for that.
All right. Well, thank you so much, Professor Brogan, for the wonderful talk and following discussion. Thank you to our audience. We had a wonderful turnout today and lots of really great questions and comments after the talk. I would like to mention that this webinar is a special edition webinar from CIS, this time joint with ISSAID. But monthly, the Early Career Immunologist Committee with CIS sponsors monthly case webinars. So if you are interested in presenting a case, please see the CIS website and submit your case there. And I hope we will have more of these special edition webinars joint with rheumatology colleagues and folks involved in the autoinflammatory area. And Dr. Brogan, I just want to make sure that you check out the chat there, because we have a number of people saying thank you and wonderful job.
Oh, thanks so much. It was great to, well, if not see you, at least interact with you virtually.
All right. Thank you, everyone.
Bye-bye all.